Okay, any audio here now? Any audio? Yes? Got it? Sweet. All right. Thanks for letting me know, Amanda. Appreciate that. Thanks, Dr. Ginia. Ooh, oh, getting a little chirp from Megan Bradford says, is this the Read the Lips series? Appreciate that. And let's see here. We got a nice one from Ilsa, who's joining us from across the pond where it's basically the middle of the night. Big Erm, thanks for being here as always. Love it. So we're going to get after it. So today, when I was doing my mime impression, what I was saying is today I've got a fun one. I think you guys are going to like it because we've just been kind of inundated with these questions, number one on our channel. And then what we're noticing on other channels is that this is a thing that people are constantly talking about. But if we're being honest, we're kind of like getting it wrong, which is no bueno. So we're going to talk about how to diagnose POTS, 4 simple steps. We're going to do the basic version. And then if there's time and interest, then I'll go a little bit further for everybody. And we'll rock and roll. Robin, middle of the night. Jen Cadwell, good to see you here, everybody. We're going to have some fun. I'm going to see if I can throw myself down in the corner here just to make it a little bit bigger. And then if that doesn't work, you guys let me know. Cool. So let's rock and roll. So we're going to talk about it. 4 easy steps. And the reason we're going to do this is because there's so much confusion about, okay, POTS is a diagnosis, but like, and then what? And then what do we do about it? And for that part, we got to do better. We just got to do better. So let's see if we can do that today. I think this will be useful. If you got anybody that's in your life that's kind of wondering why you watch these things or what you're learning, I think this one is going to be helpful to like set some groundwork that'll be very useful. So, I'm pulling these out of just the consensus statement. So it's nothing that is wild or new. Oh, what is this? Hold on. Okay, sorry about that. So it's nothing crazy or new, but here we go. So our step 1 is just super basic stuff. Believe it or not, we have to actually rule out everything else. So one of the 4 main criteria is that it can't be anything else that's causing the tachycardia. So if we're having sustained tachycardia or even positional or orthostatic tachycardia, then we still have to make sure that it's not something else. And unfortunately, I see so often, and you guys can probably resonate with this, is like we just see a lot of people that are actually suffering with different things. So we'll just like quickly walk through some of them just so we rule them out. So number 1 is you just have to make sure, number 1, you're not dehydrated. We don't have volume depletion. Like I know that seems basic, but that is number 1. Cool. Well, Robin's got a question and she wants to snooze. So we'll see if we can get that in there. But anyway, number 2 is anemias. So B12 anemia, iron anemia, these are things that can cause tachycardias, positional problems that are specific to that problem. Vitamin deficiencies, a lot of people talk about B1 deficiencies. We have to eat like a solid diet, make sure that even though we're getting a lot of calories in, that we're also getting micronutrients in. Hyperthyroidism is a big one. Simple blood work can help us understand that really quickly. We can run that. It's pretty cheap. That should be part of the workup, right? Medication side effects. Unfortunately, this one is one that we see a lot, but doesn't get picked up very well. So part of that just initial trip to the GP or even to the cardio or to the neuro should be looking at, hey, are we on stimulants? Are we on attention drugs? Are we on mood drugs? Are we on other things like diuretics? Or even, we saw 2 of them this week, even looking at blood pressure medications so like this is an obvious one, but let's talk about it real quick. So if I'm on, let's say I'm a young person, right? But I notice that my blood pressure is high. Well, initially we think of that and we go, we don't want high blood pressure. That's how strokes and stuff are made. So we don't like that generally. So then, the quick thing that we do is, or quick thing that is often done, is to put people on a blood pressure medication. But we do that without asking, why is the blood pressure going up? I mean, sometimes it's anxiety, sometimes it is we're getting plaquing, sometimes it's, we are at risk for having vascular stiffness, but other times it may be that your body is compensating for a change in blood flow to the brain. So one of the things that is a pattern that we see is that people will be on a blood pressure lowering medication that will take them closer to kind of a normal 120/80 range. But then on the other side, when we measure the transcranial Doppler, we're seeing hypoperfusion, where we're actually not getting enough blood flow when we're upright, and that leads to lightheadedness, fogginess, feeling disconnected, stuff like that. So then the question we have to then look back to is saying, well, we're on this blood pressure lowering medication. Do we need to be considering the fact that maybe the reason that blood pressure is high is because it's trying to maintain a level of perfusion, and we're actually looking at a side effect of using that medication? So that's just one example. We see the same thing can happen with stimulants, are super common, where they cause just an increased overall output of epinephrine, or changes in the adenosine pathways or in the acetylcholine pathways that can have secondary effects here. So having a look at medications can be super useful. Your GP can be really good to go through that with you. And sometimes if we're trying to hustle through a case, it can be good to say, like, here's what I'm on. Do you think that any of these things could possibly be affecting what I'm going through here? Just like, give me a second. Let's take a look at it. Okay, so the next one is just infection in post-viral states. A lot of you know that post-viral onset of POTS is super important. The caveat I'll give this one is sometimes, like, virus is gone. We are no longer dealing with an active infection, but we've got the remnants of what happened. I'm trying to fix this microphone. The remnants of what happened with, hang on. There we go. The remnants of what happened with the viral attack. So I liken this to something like a hurricane, where the hurricane comes through. If it's an active hurricane, that's probably not the time to try to start cleanup. But once we get the hurricane out of the way, if we're still having these lingering problems, right? We got the city's knocked down, then we need to do things to start rebuilding it if it's not doing it on its own. Cool? So hopefully that makes sense. So in some ways, we think of post-viral as saying, like, well, that may be the cause, but if we're starting to get to a duration of chronicity, it's getting chronic, but it's not getting better, then those are times where interventions may be really useful. And just a quick hi to Lori English. Good to see you. So I think that infection component is big. A lot of the people that are here because there's been a type of infection or an introduced chemistry into the body. Sometimes that can be just through natural causes. Sometimes that can be artificially generated, and those can be big catalysts for what we see with POTS. Another one to pay attention to is cardiac arrhythmias. So from experience, if you've got an arrhythmia and the heart isn't able to maintain its normal amount of pump, we call that an ejection fraction, or like how much blood is being pushed out of the heart. If you have an arrhythmia, that ejection fraction can go down because it's out of sync and it's not able to pump in one big push. Then we can also see these things that look like hypoperfusion or can look like tachycardia that may actually be from an arrhythmia, and that arrhythmia could be neurological, but it could also be something that's going on in the cardiac tissue. And differentiating that is a huge deal with figuring out how you're going to solve for that problem. Pulmonary embolism is another one, where we get a little clot going into the lungs that can affect your breathing, but can also affect outputs of the heart as well. Anxiety or panic disorders. if you're keyed up, gassed up, these things happen, right? People have panic attacks. People have anxiety. These are normal things that people experience. But with anxiety or panic disorders, we tend to see these accelerations in heart rate, especially as we change our breathing, if we can become hyperventilatory, or we may notice that the heart rate is going to come up with an acceleration in blood pressure as well. Those are really quick indicators that if we see all of those things are going up at once, we're sweating, we see this generalized activity, then we might want to step back and think about how anxiety or panic may be related. Now, that doesn't mean to say that if we're having POTS type phenomenology, that it doesn't induce anxiety or panic along with that. So we just want to look at what is the nature of that reciprocity in terms of how we want to address it. Okay. Interesting thing that a lot of people don't pay attention to is the fact that a fever can cause tachycardia, and that's pretty normal. It creates what's called like a hyperdynamic blood flow. So when you have a fever, part of what we do is we raise the temperature up to deal with an infection, and we also circulate the blood a lot faster. You probably can remember like a time you had the flu or had a fever, and you can feel your pulse. You can feel like the palpitations in your chest. Your blood is just ripping around, because if we keep it circulating, it prevents it from causing as many problems as it settles into areas or if it becomes sluggish. Hey, Jacqueline Frazier, good to see you. I love that you're here. And then I'm going to do one more, and then Robin, I'm going to answer your question because I know you're trying to get to bed. And then the last one here is, it's worth putting on there, but it's also, I don't know that I love it, if I'm being honest, because deconditioning from bed rest or inactivity, a lot of people that experience tachycardia experience the tachycardia first, and then because they can't do stuff, they start to have deconditioning or inactivity that happens. So there can be a measure of like we give a general rule. Like if you're not feeling well, if you're dealing with these things, while you're also trying to run the track of figuring out what the heck's going on, we also want to try to maintain as much of your activity level as possible to try to just preserve where you are. Because for every bit that we lose, it makes it harder because you got to build it back up again. So as a general rule, we want people to try to prevent deconditioning as much as possible. But I'm a little bit dubious about saying that deconditioning is often the cause for most people of the tachycardia. I think it's honestly more of a result of dealing with the symptoms of POTS or different types of orthostatic intolerance. But it's worth pointing out because it is in the consensus statement. So real quick, we're going to take a little breather from that. Like, that's step one. We got to rule out anything else that it could be. If it's anything else, it ain't POTS. Okay. And then, so let's take Robin's question real quick. She asked, we got part one. If your seated heart rate is 60 to 65 beats per minute before an injury, you have a head injury, and then afterwards, the seated heart rate can now be 85. When do you, and then when you go to standing, the heart rate elevates 95, 100. Technically, this isn't POTS. That's correct. That's correct. I'm sorry, I'm just reading another comment. So I don't know the rest of the question. Robin, you're leaving me in suspense. But this is super common. So this is like, again, for those of you that know me a little bit, know that like this is how I entered the field of tachycardia, was by noticing in our concussion cases how prevalent it was to see these alterations in heart rate relative to blood pressure. Okay, here comes part two. However, if you account for heart rate prior to head injury, which was in the 60 to 65, then it kind of is POTS. What are your thoughts on this scenario, and any thoughts on why it's increased by 20% or more? So I'm going to bob back to this part. Okay, so we always run it from like where it is now, because what you're looking at, this is actually a really good question. I think people will get a lot out of it. So you're looking at the change is the really important part. And actually, when we look at it, I know the technical criteria is that we're looking for an absolute change, like beats per minute change. But we actually also look at the heart rate delta. So we're looking at a percentage change as well for just this reason. If someone's got a really low heart rate, them accelerating 30 points, like if you go from 60 to 90, that's going to be a bigger percentage than if you were going from like 100 to 130, right? So the 60 to 90 is like a, basically a 50% change, whereas 100 to 130 is like a 30% change. So we account for that in terms of how we think about it. But when we look at these head injuries and you're looking at seated heart rate being elevated to start with, we want to think about descending cortico reticulospinal pathway. So if we lose activity to the frontal lobe, it will affect the ability to inhibit the thoracic IML, which will cause the heart rate to elevate, especially at rest. And then when we go to stand, we may see an additional elevation of that. So while this may not be strictly like, POTS, but this is a function of what we see with changes in what are called the excitatory inhibitory ratios that are very important when we look at brain injury. So wildly important. Interesting thing to look at is when you look at the different things we can do with brain rehab. So like, for example, a lot of times just doing, simple VOR maneuvers, you can end up seeing that heart rate drop right there during the movement. So this is really useful. These are actually the cases that like are the most foundational to my training in this. But yeah, so you wouldn't look at it based on the old number, but you would look at it as the compensation. What is the delta? But what we're actually looking at is this higher heart rate. We're going to have changes from the frontal lobe to the reticular system in the midbrain, or excuse me, in the brainstem, that's going to affect output to the cord. We want to do things that have an ultimate effect in that frontal system through receptor-based activity. So I know that's not a specific answer, but it kind of is. The next question would be like, well, for that particular case, what's the entry point? Is this going to be something that we do through a vestibular stimulation or an oculomotor stimulation or somatosensory stimulation? How do we combine those to be able to increase the frontal output? So hope that helps. Ask more questions. I think you'll have more, but I hope that's at least something to go to bed with. And I hope you have a great night. Cool. Cool. Okay, so I got that one, but I'm going to try to get back to what I was going to do here. Hi, Shannon. Good to see you. I'm going to get back to what I was doing here, not because I don't love the questions, but because I think this part, oh, Irene, sorry. I know Irene's got a question, but hold on. Just to follow up. So based on the case studies on YouTube with Carrick Institute, you had a 20-year-old healthy kid. You mentioned you were not happy with seated heart rate after injury. Yeah, exactly. Like the 85 seated, I'm just like salivating to try to fix those when I see that. So yeah, really good question. I'm glad you took a look at that study. Thanks for doing that. Cool. Big little comment. My heart can beat out of my chest all at once. I want to beat pre-syncope and be semi-functioning. Absolutely. Having that feeling like you're just in a fog going to pass out is brutal. I know, I hate that. Okay. And then Anna James wants to know if tilt table is the best way to test it. We're going to go over that here today. So hang with me. We'll get to it. All right. Got my Cali girls here just having a little side chat, and I love it. Okay, here we go. So let's go to the next one. Step one, can't be anything else. If it's something else, it's not POTS. So that's easy. So number two, well, if I can get to step two, what am I doing? Step two. Okay. Step two is the other one that's kind of like makes you roll your eyes and be like, oh, just get to it. Because this is, you got to determine how chronic it is. So what do we mean by that? Technically, to be in this world, we're looking at something that's just not going away. It doesn't come like once in a while. That's a different thing. It doesn't like come acutely and then go away. It's something that just persists over time. So when we start looking at POTS-based syndromes or POTS-like things, then we want to make sure that it's something that's sticking around. That's the signal that, like, man, we would hope that whatever it was just like a short-term reaction from the body. And then as you start to heal up, it should get better on its own. The kind of general rule is, like, if stuff is going to get better on its own, we want to see the needle move positively in like a 3-month span, like somewhere in that 90 days, we should see an uptick in the functionality. And if not, that kind of puts us into the game where we, like, all right, now we have to do something. That's why it becomes worth naming at that point. So 3 months is kind of the generalized criteria. It helps us figure out, like, is something coming and going? Is it acute, or is this chronic? We got to solve it. And then it rules out, obviously, recent stuff like recent illness, sometimes travel. Also, by the way, sometimes this can be travel bug, but also just the function of traveling is one that is a bit of a sleeper, because people that have vestibular problems will notice that these symptoms get way worse with traveling, which is a big clue in our world. And then I'm not telling any news here that chronic symptoms have a progressive impact on daily life and function. All right, so makes sense. Irene, I can see you. I know you got a question in there, but I'm going to try to do this part, and then at the end, if we've got some questions, I'll take some questions at the end. Cool. But yes, I do see you here. All right. Let's see. We've also got Ritvik has also got a question in there. So we're going to get after that. So Irene, I love it. I will get you, I promise. And we'll try to help you out here today. I'm going to star your comment here, and then I'll get back to you. Okay. Good to see you. Glad you're here. Awesome. Awesome. Got lots of people saying hi. Big Erm says, we see you. We all see you. I'm sorry. I was trying to read my slides here. Everybody's saying hi. Hi to you, Eileen, too. Didn't see you there. Who else did I miss? Anybody? Okay. Sweet. Love it. Love that you guys are here. I think this is going to be useful. Try to stay with me, because actually we're going to get to the part. We're going to get to, I think you're going to like this. Oh, did we go? Yeah, step 3. Okay. So this is where we actually get into, like, the clinical stuff. This is where, like, somebody like me comes in. The other side of stuff is stuff you do, like people can do on their own to a degree. I guess you're not going to be able to rule out a lot of the stuff, but that's, like, done on a general level. You go see your GP, be like, something's up with my heart. It's beating out of my chest. These are the symptoms I'm having. Is it something else? Can we do the simple basic stuff first, make sure it's nothing else? If that's persisting over time, you're like, ah, shoot, it's not going away. Then it's time to start looking at, do we need to do some testing? Okay. Now, step 3, the simple way I think about this is kind of like, this is a person's subjective feelings. Okay. So their subjective feelings, it's like your lived experience, right? So this is the symptom part. So, the main ones that people will tend to correlate to would be something like lightheadedness, dizziness, brain fog. These are the typical hypoperfusion kind of symptoms. Fatigue, palpitations. Palpitations is a tough word. So palpitations is just like the feelings that I have relative to my heart. So can I feel my heartbeat? Normally we're not supposed to feel it unless you're, like, out there cranking on the running trail or like deadlifting, 2 times your body weight, trying not to poop yourself. Like, you shouldn't feel palpitations. The main ones we feel will be hard, heavy beats, or you'll feel like an arrhythmia in your beats. Like, it'll flutter, or you'll feel a beat and then it'll stop and then it'll start again. Like, those are kind of the main types of palpitations. Shakiness is pretty common. Tremulousness, like it's almost like your body is shaking on the inside. Sometimes it actually presents shaking on the outside too. A lot of GI symptoms, nausea, upset. Then we look at things like blurred vision, muffled hearing, stuff like that. We really, the real focus of this to classify here would be that it should really get worse when you're standing up and then get better when you lay back down or sit down. Usually it's not even just sitting down. For most people, you got to get all the way to lay down. And then that helps differentiate from things like panic disorder, which I think is kind of almost in there as well. Inappropriate sinus tachycardia, which is a different thing, but you still have to treat it the same way. Orthostatic hypotension, same thing. It's just like, it's like POTS, but without the compensation in your heart rate. So all of these things are all, I want to make sure that I help everybody understand, like, just because you don't have POTS doesn't mean there's not something wrong. We want to use the language of what do you have as a way to communicate what should I do about it. So like the whole point of getting a diagnosis is to then take those words to somebody that can fix it. And I like that fires me up like you wouldn't believe, because I want to use language for people that helps them get to the promised land, like get to a solution, rather than just like use one word to describe a lot of things that you feel, which is kind of like, what does that teach us? What can we do with that? What kind of data is associated with that? So, so that fires me up in a major way. Let's use I'm trying to convey to people, like, there's an opportunity to think about it not as just like this one big umbrella, but how can we actually dig down deep into mechanisms? And I know from hanging out here that the capacity for people to get this stuff is high. I don't like that the language we use is kind of like not we, but like the general language used is kind of like pat on the head, you don't understand this language. There are like on this stream, there are very intelligent people who are very capable of knowing this and have a gigantic incentive to learn it. So I think we should share it. And that's what I'm here to do. So sorry about the rant. That's step 3. So it's like the subjective symptoms that you have that are related, especially to standing up. If you don't fit the POTS criteria, fine. It still just gives us a different thing. We can say it's not that, and then we figure out what it actually is. Cool? Cool. It's just identifying, like a lot of people identify with POTS, but then you throw it into a search or you throw it into Chat GPT, and it takes you to the same it takes you to the same stuff that is like, it doesn't get you to any sort of like real treatment. It gets you to things that are like, we can kind of sustain you where you're at, which is nice. Take a little edge off, which is cool. But as far as like getting out of it, we don't have a strong sense for that. Okay. Okay. I know I keep saying that the rant's over, but looks like I'll probably keep doing it. This is a benefit of getting me later at night when I don't have as much inhibition. So welcome to the party. All right. Now, step 4. Here's where we actually start measuring stuff. So best ways to do it. Question came through, was it Anne? Anne, I think, asked, is tilt table the best way to do it? The answer is a resounding yes, because it allows us to gather some data points. Now, if that's not available, the NASA lean test has been validated and can be very useful as far as getting you some blood pressure information and getting you some, blood pressure, heart rate, but also SpO2. You can start to get some symptoms related to that and refine what we're looking at. So it is a great starting place. Tilt table, depending on what else you're measuring, is kind of like the thing, but we'll also add a couple more tests to that to make the tilt table kind of come to life and make it more understandable in regards to what we're looking at. So the real basics is you got to measure heart rate and blood pressure, and being the key word. After this has 5 to 10 minutes of supine. You just need it to be enough to where it's stabilized. And then for 10 minutes upright, and then it needs to be for at least 2 more minutes supine again. So we got to see what happens when you lay back down to confirm that it's getting better. The simple criteria is we're looking for more than 30 beats per minute change from your rest to your upright, and then a return back toward normal. And then it can be as big as 40 in adolescence, but honestly, this number can vary quite a bit. I'm more interested in percentage change and then looking at the correlation with cerebral blood flow velocity really becomes the key indicator. as far as I'm concerned. Okay. So ideally, you want to test people in a way that it's calm, you're relaxed, you're normally hydrated, so you're not taking your, your liquid IV or your Element or your Noon tablets and then a liter of water right before you do it. Just kind of do it on like a normal hydrated state. And then you want to do it in the morning, and you don't want to do it like right after you eat. Fair enough? Cool. Big Erm, hey, by the way, thanks for speaking up here. I know I'm getting lost in the chat because we're just getting questions. We'll just let them accumulate if that's okay, and then we flag them, and then we'll get to those on the back end. Okay, so once I'm done talking about this part, then we'll kind of take some questions. Big Erm, thanks so much for letting Veronica know that. I appreciate it. Cool. And then we just, I got this little software that allows me to pin them so I can see them as they come in. And then Dr. Ginia slaps me on my wrist and makes sure that I get to everything if I'm missing stuff in the chat. Cool. So thank you very much. Okay. Veronica, yeah, of course, make comments. Lots of comments. I mean, be nice, say nice things to people, be like useful. But if you have questions, so if you have questions about what I'm talking about right now, then I'll try to answer them as they come up in the chat roll. If they're questions that are like, hey, I got this separate question, then I'll pin those and I'll talk about those at the end. Cool? Cool. Okay. So we're talking, Eileen's got a question about mast cell. We'll get to that. Piece of mung beans got a question. I can take this one right now. So she's asking about the Lumia device, which is kind of cool. It's kind of like if you took a Whoop band or an Oura ring and you stuck it in your ear, and it's going to look at skin changes, like kind of like a pulse ox would do, but you put it on your ear and then you get a normalization. I think those can be cool if you know what your normal is and you look at deviations from normal, because you're looking at an index relative to your normal. So I think they can be useful if you're trying to gauge like yourself over time. I think it's also pretty necessary to have like a baseline relative to like what should it be to start with. That's my view on it. But I do think it's a super cool technology if you're trying to measure like your day to day. So for example, let's say you're like, I went and got measured. My cerebral blood flow is really low. I'm doing this rehab strategy to try to get it back up. So what I'm doing is I measured what my Lumia said when I also got measured with the cerebral blood flow being low. And then now I can tag those two indices together. So if I see the data from my ear going up, then there's a probability that I'm on the right track with improving that cerebral blood flow. And then I can circulate back later and see if that's right. Cool. So they can be useful. It's a relatively new technology in the last couple of years. But I think they've done a really good job with that. So I actually do think it's a good tool, but I think you have to have a line in the sand first to understand mechanistically what's going on, because just wearing it mostly just kind of makes you aware of you relative to you, if that makes sense for anybody. Cool. Cool. All right. Where does that one go? Okay. Yeah. So yeah, so you said it calculates cerebral blood flow, but the way it does that is it's kind of like putting a little pulse ox on your ear. So it measures this small arterial activity that's going through like the little blood vessels in your ear. So ups and downsides of that, like you're measuring external carotid activity. So it's not the same as the internal carotid activity, but it gives you like this proxy measurement that's better than nothing, which is kind of cool. So if you can link that external activity to a measure of the internal activity and then carry that through time, then that can be useful. Cool. Okay, where was I here? Okay. So, okay, we got some questions rolling in. Sorry, guys, I'm trying to manage them both. And I know that takes me off topic, but okay, so we talked about an acetylene test. We talked about the diagnostic criteria being, we got to have the heart rate increase by at least 30 beats per minute. we like to also correlate that to cerebral blood flow, to be honest. Okay, but that's hard to do at home. So, and then the other big important part is you can't have this drop in blood pressure. So if the blood pressure is dropping and your heart rate's going up, then we know that the heart rate going up is compensating for the blood pressure going down. Therefore, the main problem is blood pressure going down, which is orthostatic hypotension. That's what that means. And the way it's classically looked at is a drop in systolic blood pressure by 20 millimeters of mercury or more, or diastolic blood pressure 10 millimeters of mercury and more. And then we can also look at that on a percentage basis as well, which I like. Cool. Okay. And the last part here you can see with these little asterisks is definitely make sure that you have to consider the medications. So for example, if you are somebody that is on propranolol or midodrine or fludrocortisone or ivabradine, and you do a tilt test, there is a possibility, there's probability that that's going to interfere with the data you get. It's not like a raw data score. You're seeing what the compensation is with the medication. That doesn't make it not useful though, because the really interesting part is we want to look at how much of these values are still in error, even though we're on the medication. So we will do that for people sometimes where we'll, obviously these tests are designed to be done just with your physiology, not necessarily with medication. But sometimes we can see that, hey, you're on propranolol and you're on midodrine, and also you're still getting this jump in heart rate and the cerebral blood flow is dropping like a rock. So we know that even though it changed some things, it didn't really change the underlying physiology. Here's how your body's compensating to try to solve it, which is helpful. Irene asked if Keppra would be on the list. Yeah, any medication. So it could be heart rate medication, could be blood pressure medication, could be like you're talking about, seizure medication or psychoactive medications, mood, attention, stimulants, anti-anxiety medications, sleeping medications, antihistamines. All of these things can affect this. Cool. Yeah. Okay. So Carol is echoing what I just said. It's measuring the blood flow in the external carotid artery. It's not in the skull. It's external. It's kind of right out here. Not blood flow into your brain. They're careful to say that. Absolutely. So you're looking at it as an index. So again, I'll reiterate, since we're on Lumia hard tonight, you have to have a cerebral blood flow study that you can correlate it to, and then you can look at that as a proxy measurement, which is better than kicking the teeth. We do the same things. We'll look at just simple things like palpating the temporal arteries. So when we measure somebody's cerebral blood flow, we'll then correlate that with what's going on in these temporal arteries. It's not one-to-one. So the same thing that causes your face to get red because you're embarrassed doesn't necessarily also cause increased blood flow to your brain, right? And then same vice versa, like doing math doesn't necessarily cause peripheral activity. So it's worth just kind of paying attention to all those things. Thanks, Carol, for chiming in on that. Cool. Yeah, Big Erm, talking drugs, propranolol and ivabradine. A little bit different beast. Ivabradine is going to be like a funny channel blocker where it just makes your heart, it slows it down, so you just get like this big forceful beat, whereas propranolol is a beta blocker and it's going to make it just so everything slows down a little bit. You get a little more vasoconstriction. Right on. Sorry I'm getting sidetracked for those of you here for the main event, but it's just conversation. We're having a good time. Cool. All right, Sandra is asking a question. Sandra, I will get to your question as, ooh, what did I do? Sandra, check that one. There we go. Cool. Cool. Right on. Let's rock and roll. Okay, so real quick, I'm gonna just run back through that real quick. So the 4 keys, like if you were just a real quick want to bang them off for people, it's like number 1, if you're having tachycardia and it's postural, got to make sure it's not being caused by anything else in the known universe. Number 2, it's got to be chronic, which means like there are things where tachycardia, even postural tachycardia, is normal given the context. Something like a fever, infection, different things like that, where dehydration, that it can happen acutely, but we hope your body compensates, normalizes it back out, gets back on the run. If it's been 3 months and it is just not budging, then we got to look at it and be like, something's up here. Your body's not able to fix itself. How do we intervene? Part 3 is, what are you feeling? We want to know, are your symptoms these kind of like either hypoperfusion or increased adrenergic activity that are happening primarily when you stand up, that get relieved when you lay down, and then we step in and measure it after that. And the measurements are largely going to be with like different varying levels of sophistication, kind of with like the lowest level of sophistication being an acetylene test, where we want to look at the blood pressure and the heart rate. However, for many, many, many people, they will have symptoms, but their heart rate may not meet full criteria. Their blood pressure was probably going to be relatively normal. We have to look at them, okay? And then where we started going down the rabbit hole of doing a considerable larger battery of tests is, it becomes very obvious when you start spending time with people that you will see people that don't necessarily fully have an increase in heart rate that helps you understand why they have an increase in heart rate. Or you may see people that the increase in the heart rate isn't quite enough to classify, but you can look at them and see that something is wrong. And they can tell you something is wrong. So we have to then say, like, well, in order to understand what is wrong, we have to be able to measure further things. Cool? Okay. Oh boy. Okay, so we got a little side chat about propanolol and ivabradine. So I'll let you guys rock that out. Yeah, people are just kind of like sharing some war stories on that. And then, okay, and then Veronica's asking about hyperpots. We're going to get to that in a second. I have my own thoughts on that I think are unique. You probably won't hear them in other places, but I stand pretty strongly with them. So what the basic diagnosis doesn't tell you. So the basic diagnosis we just talked about basically tells you that there's a pattern. And the pattern is that the heart rate goes up, the blood pressure stays pretty stable, but it doesn't explain anything about why anything's happening or what is failing. So there are these subtypes that people talk about. The main 3 that you hear everywhere are going to be hyperadrenergic, or hyperpots, as you're saying here, shorten it down, hypovolemic, and neuropathic. But I am going to talk about why I think those things exist, and I'm going to give you a little different framework to look at them in that I think is way more useful. And that is like saying a lot, but I think it's a lot more useful. Okay. So Veronica, I'm going to speak to this here. She's saying, I was told hyperpots is just very difficult to control, so I need to live with it. I'm going to speak to you on this, okay? Or not, you know what I mean? I think this is really important because I think it's really pervasive. All right. Carol's got OH. We're going to talk a little bit to that as well. We've got, yeah, so Veronica's also talking about the fact that they have MCAST, allergic to meds. So this MCAST diagnosis, this will be a thing that comes and goes. So in the autonomic world, people kind of get hooked on a thing and it gets social media popular. I'll talk about why MCAST is such a big component, or not necessarily MCAST as it's diagnosed, but why you would have the expectation that you would have changes in mast cell activity, especially because of the reaction that we're seeing to the underlying problem. So the question you have is the mast cell being hyperactive just happening out of the blue on its own, or is it happening from a compensation from something else? You can see why, if it's a compensation from something else, you have to fix the something else, versus if it's a problem with the mast cell itself, in which you would solve why it's hyperactive. Cool. Ooh, Kim's asking a good question here. We're going to get to that one. Any thoughts on how GLP-1s affect POTS? We'll have to talk about that. This is actually a whole topic that we've got in the queue to do at another time. So this is how I think about the subtypes. I think for anyone that's actually trying to find answers, yeah, Dr. Ginia says that should be its own live stream. That was kind of the plan. I'll give you maybe like a short version of that, and we'll go into it in a bigger version, maybe in a full stream. Otherwise, we're going to be here till tomorrow afternoon talking about stuff. Okay, but I love it because we have great questions coming in. This is fantastic. So the part 2 of this story is the subtypes, and I'll go through them a little bit quicker so you guys don't get bored, but I think they're important. So number 1 is we talk about neuropathic POTS. What does that mean? It means the nerves that control either the sensory end or the activity end, the motor end, aren't working. Like they get chewed up. Think about like a mouse chewing up wires. These can happen from infections. It can happen from glucose dysregulation, small, peripheral artery disease, but the big ones are largely going to be like inflammatory type processes that chew up the nerves. And we can see that because you'll see, move this down, you can see evidence of the denervation. So we do tests where we can look at, hey, do we have normal joint position sense? Do we have the sensation of vibration and light touch? Those are the big fibers. And we have the small fibers that measure pain and temperature. Guess what? Small fibers on the sensory end, same size as the autonomic motor fibers. We can look at the correlation between the sensory fibers. We can look at activity in the skin. Are we losing hair? Is the skin getting to where we're producing too much oil or not enough oil? If it's neuropathic, it'll get really dry. You'll have really dry skin, the hair will start to fall out. You'll get kind of cracked, brittle, like the quality of the skin goes down, right? Because we're not able to innervate it as well. If you want to go a little bit deeper, we can look at QSARTs, but that's specifically looking at sweat, which is going to be relative to the thermoregulatory side of this. So sometimes we'll see that the nerves themselves, while they look like they're not doing well, we always test people upright and then we lay them down. And what you'll see is in some cases, laying them down resolves what looks like the neuropathy. And in other cases, we can do things where we activate the brain and we want to see if that changes what looks like these peripheral sensory problems. And that's huge because so many people that actually have these positive skin biopsies, when we do things that look at changing the central afferentation from the brain, it changes the quality of the nerve activity in the periphery. So if that happens over a long time, the nerve itself will start to atrophy, and then you can measure that. The other downside to doing the biopsy is we're taking one punch out of one spot. We want to look at what is the difference between things that are proximal, closer to the trunk, versus things that are distal, like your fingers and your toes. We want to look and see if it's patchy throughout the body. One of the ways we can look at that is when we evaluate your skin. A lot of you guys will notice that you get that like little reticulata where it looks like little spider webs of red and white in your arms, or like purple in different spots, or just the different colors. And we want to correlate if we see those color changes to changes in the sensory system or changes in the motor system. Then number 2, we want to look at that in a recumbent position. Does it change? And then number 3, we want to look at it with brain activation and see if it changes. And for a lot of people, it does. So we can accidentally get lumped into this neuropathic one, even if that may not be the case. Okay. And then kind of the general basis of what happens is if we can't create that vasoconstriction, then we will see more of that pooling. You'll see it demonstrated, particularly in the skin and in the veins. And then that helps us understand where do we want to start stimulating this system to get that stuff to work again, start pushing it back toward the trunk. So super great stuff, really interesting, but addressing the reflexive nature of the vasculature is the thing. All of this stuff should be reflexes. How can we influence them from the brain? Recumbency, or is the nerve actually being chewed up, in which case we got to stimulate that. Those are some of my favorite to treat anyway. So let me know if that's useful for you guys. Cool. All right, just real quick, I see just a couple spots here where people are talking about some questions they have in the future. Looking at the GLP-1s, I think that is going to be an interesting slideshow for you guys. And then sharing some of like kind of your experiences with medications. Veronica, sensitive and allergic to the sun, that's a common deal. Hives, edema, absolutely. So I think this will be useful. So that's the neuropathic side. Okay. So neuropathic means there is injury to the nerves in the periphery, particularly the ones that control the blood vessels. These ones tend to be sympathetic nerves to the musculature, which we then want to differentiate from sympathetic nerves that are controlling activity in the skin and thermoregulation. I know that feels complicated, but I'm telling you that for a reason, because we need to differentiate them if we want to understand how to fix it. Cool. Okay. Next is the hyperadrenergic POTS. These are also the people that, like, I see so many people talking about MCCAST. If that's the thing you're talking about, you have to watch this, because so much of MCAS is brain. It's central. It's your brain not regulating that output, so we get increased hive responses. Way back in the day when we first started, we used to do wheel testing where we would just run a simple prick test, and we could look at activity of the brain and see if people were more responsive in their skin to these, and it was super important. So treating it as a secondary, like its own thing, and throwing drugs at it isn't always that useful. What can be more useful is understanding why that is overreacting in the first place. So when you look at that overreaction that's being defined, when they say hyperadrenergic, they're saying we got too much sympathetic activity when we're standing up. Okay, you guys got to listen to me on this one. Okay, this is why we're here. Why is the sympathetic activity high? Is it the problem with just the sympathetic problem? Okay. Is that the problem? Clinical features, increased heart rate. They will also tend to have increased blood pressure with standing, tremors, feeling heavy heartbeats, feeling the anxiety. If you get a deeper workup, you'll notice that plasma norepinephrine is high, but they don't even necessarily always use that as a criteria. We have to talk about what norepinephrine is. There's epinephrine, norepinephrine. Some people might say adrenaline, noradrenaline. Okay. So they're the same thing. So norepinephrine is the communication between sympathetic nerves. It's just a transmitter that turns a nerve on or off. Epinephrine is different. It's a metabolic neurotransmitter. It's almost like a hormone. And its job is to help you to initiate the processes that release energy, primarily through gluconeogenesis, glycolysis. So it helps us be able to mobilize and create more energy. In this case, what we're talking about is norepinephrine, which is simply the transmitter that happens between sympathetic nerves that are coming from the ganglion out to the end organ, which is primarily blood vessels. Okay, that is huge. So what's very important about this is if you are having a hard time getting blood to your head, what do you think that the typical response is going to be by your body? It's going to be trying to do more of the things that increase blood flow to your brain so you don't pass out or die. Okay? So your body is going to activate the snot out of this system. And that's what we're seeing. So, I mean, you guys have felt, anybody who's had like way too much coffee understands this. You're going to have all the symptoms that feel like you are just jacked up because in many cases we're trying to compensate for the fact that we're not getting blood in our head. So we have to solve the right problem. So by just shutting down the sympathetic activity, are we solving the problem? No. If the heart rate is up because you're trying to crank more blood to your head, and all you do is just bring it down, did we solve the blood to the head problem? Okay. So these can be compensations from cerebral hypoperfusion. That's just a blood to your head problem. Autoregulatory failure, which is where you lose the reflexes of the blood vessels in the brain. Impaired baroreflex sensitivity, where your brain just doesn't understand how much blood is being circulated moment to moment. We also have hypocapnia-induced vasoconstriction, where when my breathing changes or my my CO2 levels go down, then I get constriction in the blood vessels and I have to work even harder to push blood into the brain. It's very important that in many of these cases, the main problem is not just that like the sympathetic nerves all of a sudden grew a brain of their own and decided to cause a revolution. Okay. It's just not realistic in like writ large in most of these cases. Now, are there cases where we have pheochromocytomas where people had a tumor that released too much adrenaline? Sure. Do we have reasons where like some people have dysglycemia and their blood sugar causes norepinephrine surges? Sure. Do we have problems where we have central autonomic changes and we see spreading of autonomic reflexes where even a temperature change causes changes in my vasoconstriction? Absolutely. But these are all like separate components that are not specific for saying my sympathetic nerves they're just run too high, which seems to be the constant conversation around hyperpots. Is just like, I'm just so active. Maybe I'm anxious, or that it's just too high, which is just kind of nonsense. And what we see is that when these things start to elevate, they can spread into other systems, like we see with a histamine response. So we know, so think about this. Does anybody remember like middle school or high school speech class, where you got to give a speech about something you don't really know about very well in front of people whose opinions you super care about, and you're not a good public speaker because you've never done it before? And how many of you can remember seeing people that get blotchy skin on their face, but even more so, especially with young ladies, where you'll see like they may have a shirt and you can see like the splotching that happens on their chest, right? Why does that happen? So when we get nervous or we accelerate that arousal response, if that bleeds over into releasing these immunological responses or mast cell activity generating histamine, then I can see those changes in the skin. If it continues to spread beyond its normal boundaries, meaning normally my brain should be in charge of one thing, but if my brain isn't working really well, one thing can bleed into many things, then I may see it show up in my skin. I might just get allergic reactions to like stuff I never used to. Like you put gloves on and you get like a rash, or like you use a different soap and all of a sudden you're getting a rash, or your shirt giving you a rash, like crazy stuff. But then also that can spill over into the gut because we also have histamine responses in the gut relative to the immune system. So now I can have where I'm sensitive to food. That's like, why am I sensitive to that? That's out of nowhere. Like nobody's sensitive to that stuff. It just happens to be the things that you are exposed to, your brain over indexes and over responds to, and then you see this sequela of things that happen. Okay. So while looking at it as like, well, maybe I just need to take more antihistamines, maybe. But when you look at the allergen or the way that allergists look at this, that's what they're looking for, is like, is this a normal amount of response relative to the system that we're seeing? So if we're seeing these changes in the skin, we're seeing these changes in the vasculature, we're seeing it in the gut, is it relative to my brain not being able to independently control all these things? I shouldn't have to, if I eat some hot sauce, all of a sudden I get a rash on my skin. That's a hyperactive response, which is going to be modulated through the brain. Okay. So wildly important point. I'm trying to get through there. It reflects a failure of inhibitory activity from the brain, causing an increased output of these systems that becomes generalized and nonspecific. I hope you hear that, and I hope you listen to it again and again and again. And we don't get stuck on like, I just need to take more antihistamines. That's not going to solve the problem. I need to take more Claritin. That's not going to solve the problem. Looking at it as an allergic response that came out of nowhere relative to these things, let's back up and understand where it came from, if that's the goal, and trying to understand it. And maybe I have a goal that is different than everybody else in thinking we would want to solve the underlying. Maybe some people just want to be able to say, like, I just want to take a drug that makes me feel better. In those cases, do your thing. Cool. Okay. So if you have questions about that, let me know. But that is like super important that we understand that, because your sympathetic response is like the last resort attempt to try to keep you up and running. So what you're seeing is all the things that your body would do to try to keep you up and running, and it spills over into the corollary aspects of sympathetic activity as that feedback loop gets broken. Okay, off we go. Okay, so the third one that is super common, and I'm kind of not in the chat, so I'll come back to it. But okay, so now we're in this hypovolemic area. So that's the third one. We have neuropathic, hyperadrenergic, which you've heard my take on that. It's just a signal that we're dealing with a decompensation. We shouldn't think about it as like this sympathetic problem. We should think about it as a loss of inhibition. And then hypovolemic kind of puts us in the same thing. Is it actually a subtype of POTS? Many POTS patients are described as hypovolemic based on like the fact that they have generalized kind of lowish BP, they crave salt, or they're responsive to fluid. The reality on the fluid one, if you look at the bottom one, the bottom bullet here, is that if you give saline to basically anybody, it improves brain perfusion. So saying like, oh, you responded to doing an IV, everybody responds to an IV. So it doesn't tell you anything about the actual volume, and that was done in a study by Meadow et al. In 2008. Raj, the main reason this kind of came to be is Raj, who's a great doctor, awesome work, published a bunch, done a really nice job. But they showed that a lot of patients had low blood volume, but the way that it was done couldn't correlate that to the symptoms people had, or even what was happening with hemodynamics, which is blood flow. So these are things that we're kind of measuring as like a kind of, it's like a theoretical thing. Like we kind of assume that people are hypovolemic, but it's hard to actually put pen to paper on that because the clinical tools that are available to people aren't able to measure hypovolemia. We can do it with very specific studies in a lab, but they're just not available. Like people that are just going into a POTS clinic don't have the availability to look at that. Sometimes people will use urine sodium, renin or aldosterone levels, and orthostatic blood pressure changes, but those are not specific to hypovolemia. They can happen with anybody that has any measure of pooling or inaccurate blood flow. So the way to think about it as hypovolemia is the assumed contributor to POTS. We don't have a way to definitively identify that. And the way that it makes more sense is to think about if I'm inefficient at being able to send blood around, either because I've got a neuropathy or I've got a problem in my brain where I don't control it very well. If I can't do those, the preload or the return to my heart isn't going to be as good, and therefore my circulation is going to be impaired. So there's no gold standard test to look at it. A lot of people that have normal blood volume still have symptoms that are poor cerebral perfusion. So you can have normal blood volume, but still not get blood into your head. And then also looking at blood volume doesn't correlate with symptom severity, and it doesn't correlate with what we measure when we actually look at cerebral blood flow in the brain. So that is kind of why, like, I kind of draw the line in the sand on that, is because number one, we can't measure it. Number two, when we assume people are hypovolemic, but we actually measure changes with the cerebral blood flow, what the cerebral blood flow tells us is more useful than the assumption that it's hypovolemic in the first place. So using fluid and salt can help temporarily because it's going to expand blood volume for anyone. That's why when people have heart problems, like I've got heart failure, I'm having heart attacks, they say like stop eating so much salt because it's expanding your blood volume, which causes your blood pressure to go up. So they put them on a no salt diet or a low salt diet to try to shrink the amount of volume. So this is just trying to take that concept and reverse it and say, I'm just going to try to load up with salt and fluid in hopes that I just get more blood volume, which is the same thing as saying, I'm going to give you an IV where everybody is going to have increased perfusion based on trying to hold blood volume, but it should be temporary. If we have kidneys, we have a renal system that works normally, we should be able to detect a 1% change in blood volume in the right atrium and generate, and like we start to pee that out. your heart doesn't want too much blood pressure, causes problems. So as soon as it detects that up here, it's going to indicate that it's going to trigger to your kidneys to go ahead and start getting rid of it. Okay. So it can help temporarily, but it also doesn't mean that hypovolemia is the thing. So the more effective way, in my opinion, to look at this from my experience is to say we need to look at, is there a preload failure? Are we returning blood to the heart effectively? If not, let's figure that out. Are we seeing peripheral pooling? We can see the evidence of that. We can see if there's a neuropathic problem that is causing it, or if there is a central problem that's causing it. And then we can look to see if that feedback loop breaks down, like we just talked about with the hyperadrenergic activity, that causes us to have errors in that hemodynamic system. Okay. Whew. I feel like I've been talking so much. I'm going to step back for a second and I'm going to look at the comments. Thank you guys for listening to me and my rant. But I feel so strongly about this. Dr. Ginia sends me videos every day of people that are posting online talking about how difficult this is, but they're all looking at it through this framework. And if you look at it through this framework, there is no answer. The only answer is fluid and salts and really tight clothes. Okay. And while that can make it so that you can get more blood back to your heart, it doesn't solve anything about why it's failing. And even more so, you can do all of those things and it's still not get into your brain, which is where the symptoms come from in the first place. So I'm wildly passionate about this because I think it is like the cheat code or the unlock to be able to solve this puzzle, to win the game, is to be able to understand more about why the dang thing is happening. And if you're the kind of person that is on a live stream at this hour, wherever you are, there's nowhere where this is convenient ever, then obviously you're trying to figure this out and you want to know more about it. So I appreciate that. And I hope that like explaining this is useful to you guys and I'm not butchering it. Okay. So here we go. Okay, so Big Erm's doing an allergy panel. I'd be very curious to see how that correlates to the activity that we have relative to like feeling the palpitations, feeling the tremulousness, having the presyncope. Do we think that that is the thing that's causing the low blood flow? I wish you the best of luck. I hope it goes great. I hope you learned something about it. And I hope maybe this conversation about this frames it so that it's useful in for you. Okay, bud? Thank you. Peace, love, mung bean. Can neuropathic POTS develop secondary to a chronic lack of reflexive blood supply induced by other types of POTS? Okay, so I see where you're going here. So you can start to develop, like peripheral neuropathies come from anything that kind of chokes off the vasculature to the nerve, or, which is kind of wild, right? So the blood vessels need blood as well, or excuse me, the nerves need blood as well. And it kind of runs like a little helix around the artery or around the nerve, excuse me. And if that can get compressed, it can cut off the blood supply to the nerve and cause neuropathies as well. These are common with small vessel disease that we see in diabetes. Is a common one. Lots of things can cause this as well. So we can see like Raynaud's is an example where you see the brain, its control of thermoregulation actually causes like an over vasoconstriction, which then makes it so that like the nerves are harder to function. And people have probably felt this where you get like slowness or weakness in your hands or the sensation changes in your hands. One of the easiest ways is to just look at like how you feel something cold on your arm versus how you feel it on the back of your fingers and know like, okay, my hands, maybe they feel cold, maybe they don't, but I should still be able to feel a cold surface the same against my hand regardless. So that's like an easy way to just look at it on your own. You can do the same thing, putting it on something cold on your shin and then putting something cold on your toes and seeing if it's the same. So those can be really helpful. But yeah, the neuropathies can develop from anything that affects the output of the nerves, output of the blood vessels that supply the nerves. Cool. Good question. Thank you very much. Ritvic and Big Erm, love that you guys are able to work, kind of share your share what you're going through and work that through. Veronica says she's a quad. Hopefully this is helpful to you. POTS, EDS, MCAS, MCS. Hopefully what we're looking at shed some light on that. I hope so, because I think it's a more useful way to look at solving the problem rather than to feel like the world is just piling on you. Sandra, we're going to get to your question. I flagged it. Yeah, I'll get to that one too. Okay, so I see you checking in on it. I see you. We'll get back to you. Robin, I see part 3 of yours. We'll get back to that too. Veronica, 100 laying down. Thanks for commenting along the way. Sorry I missed them. Carol wants to know, how do you check for baroreceptor issues? Aha, that's kind of part of the next thing. So that's the question you have, is like on a tilt test, you can see some degree of that, but you can't differentiate it. But where you can see baroreceptor issues is when we look at deep breathing tests. So in that deep breathing, we should have a respiratory sinus arrhythmia. And if we don't see that, then we know there's dysfunction somewhere in that loop. It could be in the baroreceptor, could be in the NTS where it's being read in the brainstem, could be in the output nuclei, or it could be in the vagus nerve, and we can kind of sort that out. We compare that against a Valsalva test, where you blow really hard into a tube. And when you blow really hard in that tube, we get it up to a certain pressure, and we expect a certain thing to happen with your blood pressure and cerebral perfusion. And we can see if it's too slow to react, then we know that the ability of those baroreceptors to kick in and contribute may not be sufficient, or the output of the brain may not be sufficient. So we can kind of work through it like that. And depending on the waveform that generates from your blood pressure, we can understand that a little bit better. So that's why, in addition to the tilt test, we always do a deep breathing test and a Valsalva test, looking at heart rate continuous, blood pressure continuous, ETCO2 continuous, oxygen continuous, transcranial Doppler of cerebral blood flow continuous. Cool. Okay. How can you identify the root cause for dysautonomia at your clinic? I'm here in Miami, difficult to get there. Well, that's kind of what I just talked about, is you're looking at kind of the neurological activity, you're looking at the autonomic activity, and you're hunting for how those things are related and what's failing within there. And we just kind of walk through some of the component of that we look at with the autonomic part. Peace, love, mung bean. Can histamine also be a response to the body not controlling blood flow to the skin to remove heat in a normal way? Absolutely. So who was it? Was it Veronica that said kind of allergic to the skin or to the sun? So same thing. You've seen people that get like heat rash, where you're not able to cool the skin, and then we start to release the histamine as a way to resolve that. It gets itchy and it's not comfortable. So same idea. If we don't get adequate changes in blood flow activity relative to thermoregulation, then we see alterations in sweating. We see alterations in the way that we have just like normal oil on our skin. That can change the microbiome on your skin, so you are more prone to getting like weird sorts of fungus and different kinds of rashes, because you're not able to maintain the skin integrity with the normal barrier systems. And then also, if we're not able to get the heat out necessarily, then your body will start to try to compensate for that in other ways. Acne may show up, you may get rash, you may have obviously the lightheadedness and all the crappy stuff that comes with heat sensitivity as well. But absolutely, you can see skin changes because of the inability to tolerate things like that. And then the big one is having problems with being able to deal with sensitivities to the sun. People will also notice that they don't tan. So even people that like have relatively pale skin, they'll go out in the sun and they have a harder time activating that melanin system. It takes more time to be able to have exposure, and they probably still need the sun exposure in a major way. Okay. Okay, Sandra again. Sandra, I see you. I'm not ignoring you. We're gonna try to stay on topic with these. Really appreciate you. Ritvik, thanks for the compliment. Thanks for clarifying this, learning a lot today. And then the follow-up question to that, would it be correct to say that if brain retraining or any sort of limbic system training helps with POTS, it's most likely to help with hyper POTS? Ooh, I like that. I'm going to dial that in a little bit more. I like where your brain's going with that. So we can dial it in not only to hyperpots, but these would be things that are going to be relative to attentional or arousal systems that come with the limbic. So if we think of the limbic system being sensitive, it's not being gated by the frontal lobe as effectively. Therefore, it's allowed to escape. It's allowed to be more active than it should be. When the limbic system is more active than it should be, our level of alertness and arousal is going to go up. And therefore, all of the consequences of that are going to be manifest, right? So that's where we can see palpitations, high heart rate, sweating, shortness of breath that can come from that limbic activity. So when you think about brain retraining, what you're really saying is I'm going to use an internal frontal mechanism to be able to inhibit my limbic system, which can therefore allow me to inhibit the output of that arousal system. So we would classify it, moving it over to that attentional or arousal system, and using that as a way to say, I'm going to use my frontal system to inhibit that. You can also use other things to do that. That's also where things like neurofeedback, biofeedback are useful. It's the same thing, using that frontal mechanism to inhibit the limbic system. Also things that use other receptor-based stimuli through the somatosensory system, through the vestibular system, through the oculomotor system. All of these end up with outputs into the frontal lobe that cause inhibitory outputs into the limbic system. So some people find that they really resonate with self-talk, meditation, things that are kind of in that brain retraining world. Other people may find that using sensory stimuli or using reflexogenic stimuli are more accessible to them as well. So in this is where you start to kind of tease out for an individual person what's going to be the best access point, and then be able to use those to get to the outcome, which is using the intrinsic frontal lobe to be able to inhibit limbic activity. Really good question. Carol, thanks for saying helpful regarding MCAS. Let's see, root cause, just wish it would go away faster. I absolutely get that. There is nothing short of like speed is, I wish I could snap my fingers and give everybody speed so they don't have to deal with this. And feeling like C1 and C2 is a cause, and hopefully what we talked about the last couple of weeks was helpful, Eileen. Big Erm thinks maybe the hypovolemic type. Interesting. So when I think hypovolemic, I think difficulty getting cerebral blood flow, which is a different animal. And we think about what could be failing: autoregulation, neurovascular coupling, vasoreactivity, extraluminal carotid compression, baroreceptor failure, attentional changes in the brain, VOR failure, changes in brainstem. Those are the things that I'm thinking about. If it looks like it's got that hypovolemic quality, that's where I'm digging, and I'm going to figure out how to change those sensors. Yeah, Veronica, if salt doesn't work, then that, I think to a degree, I mean, that's probably what a lot of people experience in some way. Sometimes maybe it helps a little bit, but this is really, yeah, your next one is the thing, is I just drink tons of water and pee all day, which can actually create its own problem, because then you're depleting your electrolytes, which is why things like all these electrolyte drinks and tabs and products become important, because we overconsume the water, so we have to overconsume the electrolytes as well. But that electrolyte mix, what we don't account for is a lot of those minerals are trace minerals too. They're not just sodium, not just potassium. There are all these trace minerals that we have as well, so we want to replace the trace minerals too. So actually, drinking a ton of water can actually be counterproductive for a lot of people. Plus, it makes you wake up in the middle of the night, can give you tachycardia in the middle of the night, makes it hard to sleep, and then that makes things worse too. Okay. Yoga, walking, resistance training, improving. So a lot of people that feel better with those things are people where you're activating muscle activity, and you're causing a musculogenic return back to the heart that allows you to be able to generate blood flow. And in a lot of these cases, we think about neuropathic types, but we also think about problems with autoregulation. For those of you that have been deep in it post the virus we can't talk about, everybody was talking about endothelial dysfunction. And then that got added to the vocabulary. But what does endothelial dysfunction mean? Well, endothelial dysfunction, what we're talking about is the signaling mechanism to be able to detect the pressure in the vessel. This is a reflex. This is a neurological reflex. And when we do that, then we can't control the normal contraction and dilation of the vessel. It becomes pressure passive or harder to push blood through it. And then we can cause perfusion problems to the brain, organs, to the body at large. And then so we see that the ability to transmit those signals gets impaired. We also know that if we swell a blood vessel, it makes the hole smaller and it makes it harder to constrict and dilate and control that. So it's like if you got a swollen ankle, it's harder to move your ankle. Same idea. And we're going to have another separate live on that. Honestly, I'm figuring out how to do it while we can talk about the virus you're not supposed to talk about without getting kicked off the platform. So we'll figure out how to do that too. Cool. Peace, love, mung bean. Will a structural cause present as POTS in some cases? It can, because, so let's say I got a structural thing going on in my neck, like you're talking about, and I cause an extraluminal compression, right? So it's harder for me to push blood through the carotid. My heart is going to have to try to work harder to push that blood up to my head. So anything that causes difficulty pushing blood into your head, your heart and your vessels have to try to work harder in order to do that. And that can have the expression that we see here. Yeah, Eileen. Yeah, electrolytes for a lot of people are just like that thumb in the hole in the boat where it's like, I'm going to use those babies because they help until I can figure this thing out. And you just jam that thumb in there, keep the water from filling up your boat. And Carol says, thank you very much. No, it's a rant. It's all fascinating. Dr. Ginny just sharing a little bit about her story with POTS. She's just been wonderful. She's super helpful, super passionate about this, and is gone a long way to help us out and being able to share this with everybody. So I really appreciate her. Hey, Sandra, I hear you. You gotta stop filling my chat with that though, because it makes me feel like you're pressuring me here. So I will get to it, I promise. But also, I haven't looked at it yet, but I'm concerned that maybe you're asking a question that's specific to you, but I may not be able to answer that specifically because I can't give medical advice. Okay. I would love to hear. Oh, sorry. So I'll let you guys read about Dr. Genia's experience. Makes me blush to hear her talk about it. It makes me like, yeah. Anyway, we love her. We're so proud of her, and we think the world of Dr. Genia. No matter over normal. Good to see you again. Coming to your clinic next week. Busy packing right now and have to bounce. Might listen to this one on drive out from New Jersey. Excited for you. We're super excited to have you. Can't wait to meet you and do it in person. Awesome. Irene McBean, does Raynaud's affect lowered blood supply to the brain? Yes, great question. So we're using it as a parallel. This is a thermoregulatory version of that hypervasoconstriction. So like a temperature-based version of this. But then we also have to remember, like, lots of things cause this in the brain, especially migraine, changes in CO2, changes in oxygen, changes in arousal, changes in temperature, right? So the same way we can have that too much vasoconstriction in the hands, we can do that in other places as well, particularly the brain. It doesn't have to be from temperature, but temperature is the obvious one, especially in the periphery. Really good. I love that you linked that together. I got doctors that don't even do that, so that was really good. Okay. Amanda, thanks for reaching out to Sandra. I really appreciate that. Okay. And then Dr. Ginny is just kind of managing some stuff in the chat about her story. I'll let you guys read that. Yep. And then follow up from Peace Love Mung Bean. Another reason activity could drive symptoms. Absolutely. I love it. You guys are getting it. I love it. I love it. I love it. Eileen says goals to get back to the pool. PT doc says we'll get there. Love it. Actually, a lot of people, separate thing here. A lot of people do really well in the pool because it creates hydrostatic pressure. So if we're having cerebral problems, being able to like push all of you and create normal pressure can actually increase blood flow to the brain. What's interesting though is if it becomes symptomatic, then we start looking at other things regarding sensory systems, like the somatosensory system, like the feelings in your body, versus your vestibular system and your ocular system. So people that get symptomatic in the pool, we look at that relationship. If you're looking for more on that, go back to what we talked about last week, and that might give you an indication of why, even though in the pool should make blood flow to the brain better, I can still be more symptomatic because of the mismatch there. Cool. Sweet, sweet. After an adjustment, my nervous system gets upset and agitated for a few days. And that might just be related to the fact that the adjustment may, could be a lot of things, but it may just be that it is upsetting the system. So if we change and we create a sensory mismatch where we steal a compensation, it can make you feel worse. Okay. Oh, Kelly Harding saying, dropping in to say hi. Love it. Thanks for doing these. Always great. I hope you guys are doing great. Say hi to the family for me. And I hope you guys are doing awesome. Thanks. Oh, Veronica says, I'm going to a renowned neurology institute soon. Good luck for that. And if they can't help me, forget to see Dr. Keiser. I hope they can help you. But also, I am definitely here if you need me. So let me know. Okay, so big arm, I think this is a good question. So if we come to your clinic, step one, determining what subtype of POTS we have. Yeah, so I don't even think about it in subtypes per se, but I think it's easier way to communicate it. And we haven't even gotten into the ones that are my favorite, and it's already 9:30. Yeah, so it's determining, for me, I think about it in terms of mechanisms. So like if we were to just think about you like a machine and say, for the machine to act like this, what would have to be not working correctly? And then how do we solve that? Is like the simple way to think about it. And this kind of wraps a little bit around some of the language to help us understand where some of those things break down. I don't get into the full depth here because I mean, I actually have a course on this that I taught that was like 150-hour course, but we only just got like a toe deep into it. So there's just a lot to talk about, but I really love that you guys are here. Big Arm, you've been a great contributor. I appreciate you. Can you have POTS without swelling in your hands and feet? Is blood pooling then happening? Wait, hold on a second. Can you have POTS without swelling of the feet and hands? Is the blood pooling then happening in the abdomen? You can have POTS without swelling anywhere. I think that's a really important part. We see tons of people where pooling isn't like the main thing, even though that surprises a lot of people. So don't be dissuaded if you're not swollen everywhere. Can it be pooling in the abdomen? Yeah, because anything below the heart, it's going to sink into that. And the vasculature in the abdomen is super dense because it's controlling all of the blood flow to your gut. And that's where all the magic happens with being able to distribute nutrients, but also to be able to like stand guard of the immune system. That's a good question. Oh man, I love that you guys have questions, and I am so behind. Dr. Ginny, are we going to end up with another part 2? Am I going to have to tease out the next part? So the actual ones that I think are the most interesting subtypes are actually cerebral hypoperfusion, hypocapnic or hyperventilatory hypocapnia. So I think that there's like so much more to get into. So I might have to do, yeah, Dr. Ginny says, yeah, we might have to do a part 2 on this. So I'll try to do my best, but it makes me super happy to answer the questions too. So it's all good. All right. Let's see. Veronica didn't like tilt table test. Yeah, I get it. A lot of people don't. Actually, most people that come in, not most, a high percentage of people though are freaked out about the tilt table test and actually pleasantly surprised. So if you do it well and you don't juice people and you don't like try to kick them in the mouth with the intensity of it, it's actually a reasonable test. Does it feel perfect? No, but But what you trade for the discomfort, for the data that you get when you actually measure everything, I think most people would say like they would do it. And so if anybody's out there and worried about that, the way that they do it definitely matters. Not making people suffer through it and push too hard. When you look at cerebral blood flow, you can see pretty quickly if someone's going down, so you don't have to like stand there and confirm that they're gonna, pass out. You can get the data on the way, and then that's helpful because like we have people that last 1 minute on the tilt test, their cerebral blood flow drops through the floor. We pull them down and we say, okay, well, that's how far we made it. Here's what happened. But then we'll do treatment. So I can think of one where you made it. It was less. It was somewhere between 1 and 2 minutes. I won't get the number right, but that's pretty short. But one of the beautiful parts was like going back through it. It was like, okay, we're going to test this again in a little bit. And when we did, it's like, sweet. Now I made it 6 minutes, no cerebral hypoperfusion. Then I start to get like my endurance goes down. Then I get fatigued. Cool. I go to 6 minutes. Can I get to 8? Can I get to 10? Can I get to standing? And away we go, right? So you have these little markers along the way so you can see if you're winning, which is, I think, is just the coolest part. I come from like a training background, so I like to see those little incremental improvements. And then like, oh, shoot, it's working. I'm going to keep running. So there you go. Last year I went to Vegas, had 3 adult beverages, never again, and then had a huge response, heart racing, peeing every 2 minutes for like an hour, palpitations, couldn't calm down from it. Deep breathing, went to ER, told me anxiety. I thought alcohol was a depressant. I told them, they said I had an opposite anxiety reaction thing. I don't drink anymore. Yeah, so you know what? It seems like on the face of it, you read that question and be like, okay. But actually, there's a huge little nugget in there. It's because when you think about what alcohol does, is we think about it like, oh, it removes inhibitions, right? People talk about that. It takes away my inhibitions. Inhibitions or inhibitory activity is precisely what keeps all this stuff under control. So if I have alcohol that affects my brain's ability to inhibit, it probably is amplifying something that's already underneath it. So if I'm already struggling a little bit to keep the inhibition of this cortical reticulospinal system intact, and then I just wash it out with some booze, then we can see that those things accelerate. So this is kind of along the same phenomenology we looked at in the very beginning when I was answering that question about having a high heart rate seated, and then that heart rate elevating even more standing in someone that's had a traumatic brain injury. So you can think about this the same way. We're just doing like a temporary traumatic brain injury where we wash it out with alcohol, we see the same effect happen. So there may be something underlying that where you're just exposing it a little bit. So that's actually like a useful little tidbit for everybody. And then Irene McBean, could you go over again the cause of restricted blood flow to the brain that don't present with lower blood pressure? Yeah, so these could be anything where we're causing anything that interrupts blood flow basically from the heart to the brain. So that could be something pushing on the arteries, that could be something inside the arteries, and it could be the arteries over constricting. It could also be problems with autoregulation, which is the reflex that controls the amount of pressure inside the blood vessel. It could also be from changes in vasoreactivity, which is just the sensitivity that we have to carbon dioxide, and that also causes a vasoconstrictive reflex. Brings you changes with neurovascular coupling. These happen mostly in brain injury, where when I go to use an area of the brain, the normal reflex that happens that should draw blood to it doesn't kick in. And again, we see that hypoperfusion as well. You can also see in changes with baroreceptor activity from the baroreceptors in the neck, where they just don't get the plot anymore and we don't push enough blood into the head. We can also see it with changes in the processors in the brainstem. Those also correlate with problems with vestibular problems, somatosensory problems, especially like ones in the neck and in the spine, like we talked about last week, or oculomotor problems. These are predominantly seen in brain injury, concussion, infections that affect the brain. So all of those things can present with hypoperfusion, But what you'll actually see is like the brain is like, I'm crushing blood pressure right now, but we're not able to transfer that corporal or systemic blood pressure into blood pressure in the head, because those two systems function a little bit differently. The reflexes are different because in the body, I don't have to worry so much about the amount of pressure going through a vessel, but in the head, it's like a Instapot, right? So if I have too much pressure that goes in, I've got a skull, so it just creates pressure against my skull and can damage the stuff on the inside. So that the way those reflexes have to work in the brain are different than they work in the rest of the body. Okay, good question. Thanks for asking me to go back through that again. Rachel just says cerebral artery disease, ICA, MCA, ACA. Okay. Causes to be determined. I hope that, let's get to the bottom of that, and love the channel. Thanks for information relative to hypophofusion. Yeah, happy to help. I think I'd be very interested to see kind of what's behind that, and I hope it's good things for you on the other end. Good luck. Okay. Okay. So Sandra's back. I'm going to read hers. First diagnosed with POTS, then after PT got sick, and now low blood pressure and heart rate on the tilt table test, erratic muscle contraction, what could be causing it? Everything happened 15 days, physical stress, fall. Then I hit my head. Now I'm struggling for more than a year. So this is an example of that, like where I actually have an idea how to help you, but I can't give you medical advice on the stream. That's not responsible. But what we can talk about is kind of some writ large things. So, so we first got a POTS diagnosis, and now we've got low blood pressure and heart rate on a tilt test. We're kind of looking at something a little bit different here. So low blood pressure, low heart rate is more associated with orthostatic hypotension or vasovagal syncope. So that would be kind of the first question. That's going to give you one type of phenomenology. Erratic muscle contractions can be from a number of things, especially anytime where you are interrupting blood flow to the brain. All sorts of weird stuff can happen, because if I get hypoxic or hypoperfused in any one area, whatever's in charge of that area isn't going to work right. So it may happen to change, muscular contractions. It may affect your speech, may affect your vision, may affect your heart. So you kind of looking at that writ large, we want to see, like, is it something that's coming from that hypotension and changes in supply, or is this from an injury itself where I've damaged the neurons and they're not firing as well as it could? If that makes sense. So for it to be 1 year struggling, this speaks to that chronicity component. Normally, we like to see the general trend of the body should be toward healing. It's always trying to heal and get us back to normal. If we're in this standstill and it's become chronic, now we're looking at something where whatever the body is trying to do to adapt isn't enough to get us through that problem. I mean, and then that's not abnormal. You see the same thing, like if I break my arm, I still would like to set that arm so as it heals, it does it correctly and it doesn't heal with like a crooked arm. So same idea, where we want to step in and look at why is it not healing, and then what can we give to the body as far as the stimulus goes that will allow it to be able to find its way again. Maybe it's reducing a dosage of activity that we're doing. Maybe it's increasing a dosage of activity in a particular field. So I hope that's helpful. And I just realized something, Dr. Ginian, that I've had this same hypovolemic slide up this whole time while I'm answering questions. I'm going to switch myself to the full screen mode while I'm answering questions. That might be better. Didn't realize I was doing that the whole time. So that's good. And you guys let me know. Let me star one here so I know where I'm at. And then let's see what we got for questions here. Okay. So I'll keep doing questions. You guys let me know what you want what you like. I still have more of this presentation to go. It's kind of weird to stop in the middle, but also I can see that a lot of people have a lot of questions. So let me know if that's useful for me to answer the questions, or if you'd like me to do And this is for this stream, but also others, because we run into this kind of consistently. So let me know if you guys prefer like the question answering, or if you like the content part, or kind of like how we should organize this. Or if I do the content part, should I make it a little bit shorter in the beginning? Let me know what you guys prefer, and I can figure out ways to make it better for you. Okay. 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 More love for Dr. Ginia. We appreciate her like crazy. Yes, I have a, Eileen says I have a balance, so pool can be hard. I'm assuming that's a balance problem, but I want to sit. I want to sit in the pool and get a little tan too. I like that. That sounds great. Yeah, anything we can do to get you outside, get you a little sunshine. Sometimes people feel better if you can kind of like anchor to the ground while you're in the pool. Even if you just get up to your chest, even better is up to your neck. Get a little blood in your noggin. That's super great to whatever, but you got to be safe. If you got a balance problem, you can't go to the pool by yourself. You can't risk drowning, can't risk falling. Deal? Okay, that'll be our deal. Okay. We got another swimming pool question from Sandra. It says, what about swimming pool for dysautonomia, low blood pressure, heart rate, and tilt table tests? Okay, so we're back to that. So like we said, being in the pool gives you hydrostatic pressure, so it can make you feel a little bit better because it's going to just generally push blood up, especially if you get high enough. And the other part of that is also when you say what about it, it's gonna be good. It's gonna be good in the moment, but it doesn't necessarily train your brain to do that, because as soon as you take the orthostatic pressure away, you take away the thing that was pushing blood to the head. So if you want to try to solve it like longer term, then you figure out, well, what is the thing that could help me push more blood to my head that I could carry around with me on a regular basis. But for some like respite, for being able to recover, doing that in the pool can be really, really useful. Or if you want to get in and do just some physical activity in the pool, sometimes that can be a little helpful, because I'm at least keeping some perfusion while I'm doing physical activity in the pool. Again, do it safely. Do it with a helper or a lifeguard or a life vest and a snorkel. Be safe out there. Okay. Bigger, thanks for your time. I appreciate you, man. Thanks for being here. Okay. Bloating while running is interesting. I'd be interested to know on that one. Oh, here we go. Says it's only when I do cardio exercise that I get bloating, 15 to 20 minutes after, and then palpitations with that. Okay. That's an interesting one. So bloating after, a couple things to think about actually is when I think about bloating, I think about the first differentiation is going to be, is that bloating air or fluid? So if it's air, sometimes, especially after running, you may find that the way you're breathing, you may be swallowing air, which is kind of a weird thing to think about. But you'll know that because it's tympanics. Like when you tap your belly, it sounds like an air-filled drum. Whereas if it's fluid accumulating in the gut, then it'll feel like fluid. And so that's like the first step. So if it's more air, obviously you got to solve that problem. It's more fluid. You want to look at why there's a fluid accumulation. Is that swelling relative to pooling that can happen? That can be a big one, especially if you're getting tachycardia right afterwards, where you're just seeing like a dilation of that arterial tree. It's not able to keep up, and then we don't get the normal preload to our heart, and you can see it start to pool. You may note that you may see like if you're getting more vascularity in your hands or in your feet, or if they're feeling swollen, or if you're getting swelling in the legs as well, would be interesting to look at. Brad, what were you laughing at? Just throwing laughy emojis out there. No context. Don't know what you're laughing about. What would you call it if a patient had POTS but is recovered enough that the rise in heart rate is less than 30 beats per minute, but still lots of faintness and lightheadedness? Is it still POTS? Well, technically not, but where we get into subtyping, this is where we do that little extra push of diagnostics to see if we're having cerebral hypoperfusion, if we're having problems with hypotension. But these are like these are the cases that got me into the deep dive rabbit holes of doing more testing. So I was seeing these cases where people had these obvious symptoms. I could see, so I would do dual tasking with people on a tilt test, but their heart rate isn't going up. It's going up 20 beats per minute, which is like, maybe that's not great, but it's not out of the ordinary. Blood pressure is fine, but I can watch them failing. I can I can have them doing like math on the tilt and they are just bombing. And then I can lay them down, boom, and it comes right back. I'm watching people lose their ability to talk and then lay down, it comes back. I'm watching people lose their vision. I'm seeing people start to twitch. I'm seeing them shaking on the table, but these things are normal. And like enough of that was like, I have to see what's going on in their head. We're missing something. And then that led me to looking at transcranial Doppler ultrasound. And with transcranial Doppler ultrasound, I learned from Dr. Novak that in order to understand that correctly with vasoreactivity and autoregulation, we really have to understand hypocap, or we have to understand end-tidal carbon dioxide with that. And then, so like, as we're doing these things, we're bolting on ways of understanding and digging deeper. And we're doing dual tasking, we're doing color change activity, and we're looking at cranial nerves and all of these things. We're looking at head positioning, we're looking at arm positioning as ways to understand why these things are happening. So these are the cases that took us there, are these ones where it's like, I don't quite fit in the criteria. And it's like, well, I'm not, like, the criteria doesn't matter. We have to figure out how to fix it. And then, so that's where these come from. And that's kind of like the second half of what I wanted to talk about that I was hoping would be interesting to everybody. But thanks, that's a good question. All right, we're rolling. Oh, back to our tilt table question. I'm sorry I'm out of sync on these, but Veronica was like, I hated the tilt table, to be honest, but I also still do the tilt table. So wise words. But yeah, it's a little bit, it's nerve-wracking for people. A lot of people are like psyching themselves up when they first come in to do that. Peace, love, Mung Bean. Can we have a YouTube video where all these subtypes are explained together so we can share with other POTS patients? Okay. That's what I made this presentation for. Let's go ahead. I'll just have to make a separate video long form, and we're working on it. So we have everything available to do it. I can do a long form of this uninterrupted, and that way it'll all be in one place. If you guys don't mind, would you please comment and just write long form if that is something that is interesting to you? Okay, cool. Thank you. Thank you for doing that. Shannon. Nice to meet you too. I'm really looking forward to it as well. It's going to be really fun. It's going to be great. I'm glad we'll see you next week. Carol said I lasted 3 minutes on the tilt table test. Felt horrible, but so glad I did it. Terrific info, worth it. Yeah, thanks for saying that. I think that will give a lot of people some encouragement, because it can be daunting. But it's the same, like, all this stuff that you don't know can be super intimidating. Even just like traveling to go somewhere, getting in the car, if you're spending all your time in the house, getting out of bed, like all of these little incremental steps can feel really big. But so many of these people have like gutted it out and decided, like, I'm just going to do this next piece. Okay. And so I think that's really useful. Thanks for sharing that. Dr. Ginny wants to make sure everybody knows they can email. We have like a separate email that we made for this, and it's keisersocial@gmail.com. KEISER social, SOCIAL @gmail.com. And if you want to email things that you're interested in us doing, especially long form content, we've started filming new long form content, which is exciting. But if there are things that are useful to put in there, we will put them in the role, and we're going to try. I'm going to say this publicly, even though we're trying to work it through, because we have kind of a long clinical hour. So obviously I do a lot of this stuff off hours. But if there's stuff in there that you really want to see, let us know, and we'll try to put that into long form content. Veronica, spinal tap is painful, but I felt like I was dying during some parts of the tilt table. Yeah, but here's the thing. If the tilt table exposes you and makes you feel like your symptoms are bad, the chances are, if we're testing enough of the right things during that test, it's also going to expose the why, which is beautiful. So silver lining there. Sandra, my dysautonomia is triggered by a hard physical stress and fall hit to the head. Still 1 year looking and struggling. Yeah. So like I had mentioned before, this is the prime example of got to get you to somebody that can take a look and try to correlate how the traumatic brain injury or whatever the other physical stress is, what effect that had, and try to unwind why it's happening, and then that can get us there. It's hard to do remotely. So I would just say for everybody that's here, doing this type of work remotely is brutally hard. Like I don't do any of it remotely on an exam basis because you have to observe what's going on with people. If you try to do it without observing, it's amazing. You can be super talented, and it is amazing how far off you can be without actually evaluating it. So while I am tempted also by telehealth, and it would actually, honestly, like if I could see people online, it would make my life way easier. But the reality is like it's just not feasible. And most of you will find that attempts to do it, you'll just kind of end up barking up trees and spending money, and like you don't really get anywhere. For those of you that do get places, I love it, and I'm super happy for that. But my experience with it is with how to do it is I would have no way to be able to implement the testing strategies, the treatment, without being able to observe someone one-on-one. So it's also kind of why it's hard also to recommend like, hey, you should go here to be able to do that, because it's so hard to be able to it's hard to say like I'm going to put my thoughts in someone else's head and they're going to know what to do. They're going to have the same equipment. We're a very unique clinic, very unique way of thinking about it. So sometimes it's hard to recommend that and know what we're going to get on the other end. So there's some practitioners that I love and respect and I think are wonderful, but it can be hard to just say like, oh, go there and they'll take care of everything. So we try to do that best we can, but it's not always the easiest way for us to do that. So I hope you guys understand that. Okay. Could it be harmful if head pressure gets too high at first when the POTS patient lays down flat? Ooh, good question here. So, and I like how I can tell you're asking this question for a certain someone, but I like how you frame it so that you're not asking me to give specific advice. That's very smart. Okay. So if you're feeling high head pressure as a POTS patient, so if you're getting tachycardia orthostatically, but then you're also feeling that big pressure when you're laying down, that's something we want to pay attention to, because what it typically insinuates is that we're not doing a good job of gating or restricting pressure laying down. So normally when you lay down from standing up, now my heart is going to have a way easier time getting blood to my head. So rather than asking the brain to pull more or to like accept more blood, when you lay down, it's actually going to have to restrict it and like shun some away. And if the systems that would normally be in charge of that are too slow, then we'll see on the way up, blood rushes out. On the way down, blood rushes in. So the common feature of that is like really hypovolemic and like feeling like you're going to pass out when you stand up. And then also when you lay down, you get a big rush. And a lot of times there's a pulse to that. And in many cases, one of the things that's going to be top on the list to look at will be, do we have normal autoregulation? Is the reflex of the blood vessels working? And a lot of times when we see those, that's the thing. Cool. Cool. Irene McBean says, thank you. Oh, we're losing Dr. Cadwell. Early morning, got to sleep in. Great as usual. Please say hi to the rest of the team. We love you. There's a live with Jennifer Cadwell. If you guys are interested, go check that out. We did it, I guess it's maybe a month or so ago. But yeah, thanks for being here. Carol, in for the presentation. I like the presentation too, but I love answering the questions, so I can go both ways. Thank you for letting us know that. Maybe we're gonna have to do some long forms, huh, Dr. Ginia? And like long forms there, and maybe do long forms with some Q&As in the live. That might be the way to do this. And then maybe the questions that are like, ooh, that's a long answer question. Maybe we start to go for long answer questions and we convert those into long form content. And then that way they're more shareable. I think what happens in these is they're harder to share because it's just like boom, 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 and it gets long. So maybe the ones that really hit for people, you guys could like give us a shout. Like there'll be a magic word. Maybe we put in like the topic and then long form so that we can grab those in the chats and we'll catalog those and we'll make those into long forms that stand alone. And then that way they're a little bit easier to share with your family and with friends and stuff. Cool. Okay. Let's see. So Megan Bradford, can hyperbaric treatment help increase blood flow to the brain? Is it something that helps long-term or just during the session? Great question. So hyperbaric oxygen is what we're talking about, hyperbaric oxygen treatment, where we're basically back to the Instapot analogy, where we're creating pressure with the oxygen, which allows the red blood cell to be able to have more affinity for oxygen, which just means you can load more oxygen per unit of hemoglobin, which allows you to basically push it deeper into the cells. So if we're having cells that aren't getting as much oxygen to them, we can push more oxygen there and we can diffuse it across when we go to use them, then hopefully we can kind of revitalize them. So it kind of has to couple to activation. We know we need activation to stimulate a cell, but if we can also get more oxygen to it to help it heal, that can be very beneficial as well. So it can help during the session because it can create dilation, especially if we're having autoregulatory errors. It can be really helpful for helping to train that. So that's during the session. And in some cases, we can see that plasticity occur over time. With hyperbaric oxygen, you also want to be patient because it's going to take time for that to happen. So if you go and expect to do like 2 or 3 dives and see a result, it's probably not going to get you where you want to go. But if you're willing to do, most places will do like a program where they'll have, a set number of sessions, 40 or 80 sessions. And that's probably more of the scale to think about it on, is doing that whole series of sessions. Usually they're an hour, hour and a half, a couple times a week. Sometimes we'll do them more consistently than that, but it can be a really great tool. I've got a great friend in Maine, and there's a great clinic in Michigan, even though they're so Oxford's great in Michigan. They do a great job. And then there's a great clinic. I have a friend in Maine, and you see some really cool things with them. You just gotta be patient, willing to stick it out. And then there's probably a measure of activation that has to occur as well. So you gotta target activity to the places you're trying to heal while also delivering oxygen to it. I think that combination is really, really potent. Carol says maybe presentation first, questions afterwards. I tried to do that. I think where my error is I get excited to do the presentations. I'm used to teaching like 25 hours at a time. So I think I over prepare and then I make it long and then I don't get through it all. And then obviously during the course of the presentation, that creates questions. And then I'm answering those questions and then I don't get all the way through the material because I also have to go to bed. Okay. Da-da-da. Irene says, thanks. What you're doing is already great. Jeannie, very helpful too. Thank you guys so much for that. Awesome. Eileen says, hubby's gonna be with her. That's awesome that your husband's there to help. I love a good support team. There's a lot of great husbands, wives, moms, dads, even kids that are just rock stars being able to help people. And I certainly appreciate you guys. Thanks so much. Goes unsaid too often. Really appreciate it. 30-minute contents, long Q&A at the end, returning. Yeah, it's probably pretty good. 30 minutes. 30 minutes might even be high. You guys are good question askers, but I like it. I like that format. Okay. Is it more common for folks with head injury and POTS that they get POTS immediately with their head injury, or does it come on a while after the head injury? Man, you got them loaded up today. Is it methicin or methicin? Methicin? Great questions today. Love it. So it can go both ways. So a lot of people that tend to have more of the dysautonomic or POTS type findings, we see them come more in like the post-concussion range and like it's always going to affect it first because there's going to be a change in neurovascular coupling. It's part of how your brain heals when it's injured. And then the question is like, does it respond well enough or does it start to drift into adaptation? So it's kind of like the longer the concussion symptoms go, the higher likelihood someone's going to have autonomic findings. And one thing that they noticed in Letty's work was that the ones that responded the worst to exercise training as a way for solving the concussion were the ones that tended to have autonomic problems. So they can show up a little bit later. For some people, it's right away, but a lot of them, it can even start like months down the line where you're just grinding, and that heart starts to, like the compensation goes up, 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 up. So that's not uncommon. Another great question. Really appreciate that. Thanks for being here tonight. And limit the number of questions each of us can ask. If time is limited, more time is available, more questions could be asked. That might be something we could do, just to do that. I don't know how we would limit it. I don't know. That's a good question. Carol, maybe you help me figure out how to do that. Long form, sweet. Long form from Matheson. I hope I'm saying that right. And then Ritvik. And then TBI doctor telling me that intracranial pressure would only show up as encephalitis or something dire. I'd understood that there could be nuanced problems with low level of pressure, i.e. optic nerve pressure. Yeah, so you can see like idiopathic intracranial hypertension. You can see, we talked about this a little bit last week, but a couple places you can see it. You can see subtle changes with papilledema, looking at a fundoscopic exam, simple with an ophthalmoscope, where it just swells the optic nerve, and that compression of the optic nerve, pushing it into your eye, can be an indicator of too much pressure in your head. You can also see it with changes in the retinal cells if you do an OCT. So those are both pretty obvious. You can also see them just with distension in the veins or difficulty generating pressure. So like a narrowed pulse pressure on the cerebral blood flow velocity with the Doppler. And then also like an increased pulsatility index can also indicate that. Sometimes you'll blow a pupil, sometimes you get cranial nerve signs. But it doesn't always have to be encephalitis for sure. I mean, you can get swelling in the brain, but you can also get it from changes in cerebral spinal fluid, as well as venous drainage, arterial activity. We talked about this last week a little bit with Chiari malformations. And if we're not able to drain that flow out, you can also see it with changes in the structure of the upper cervical spine, which causes changes in the ability to circulate that fluid too. So yeah, you can see it in lots of different things. Spinal or doing a lumbar puncture is the way that it was the classic way to look at pressure, because you just see like what is the opening pressure, like how much you pop the balloon, how much squirts back at you, basically. So those are the kind of main ways. Those ones are a little tougher because you can have complications with that. But I like the other two as a scout view, looking at the OCT and looking at the fundoscope, and then just looking at the observable bedside exam. And then if you need to, if you're unsure, then you can progress to looking at the lumbar puncture and understanding why. And a lot of times you want to get some imaging too to see if something structurally is going on. Ooh, Amanda, good point. Long form may help the newly diagnosed. Yeah, I think you're right. Let's do this one in a long form and I can stretch it out a little bit, and then I won't be sidetracked and like go off topic too. Good idea. Dr. Genia just posted the email if you guys want to contact us, give us some ideas or say hello or just give us a high five. Cool. Dr. Blair Grubb invented the POTS diagnostic criteria. He said he believes the criteria are too restrictive for clinical use. Yeah, he was part of that team. They do it in consensus format, so they kind of take like a big swath of people. Some of the original stuff was done out of Mayo with Dr. Lowe's work. Dr. Grubb's done a lot out of Toledo. Super great. too restrictive for clinical use. I think so too, but I also think it's not just the criteria for POTS, but I think we over-index toward what POTS is. I don't think we should name things based on symptoms. I think we should name them based on mechanisms. And I will probably say that like for the rest of my life until someone changes my mind. I just think the mechanism is so much more useful because the reality is all this stuff is to try to fix it. We're trying to solve the problem. So just describing what people feel isn't always that useful in helping us solve the problem. And I just feel super strongly about that. So yeah, thanks for that little hit for everybody, a little history lesson. He's actually he wrote a paper. He's a really good writer. He wrote a paper pretty early on. I'm trying to remember what year it was. But I have a couple presentations where I use some quotes of his because he's a very elegant writer. I'll have to dig those up and try to find them. Carol says long form. Oh, I forgot all. Sorry, Kim. GLP-1 next week. Sorry. Yeah, we'll take some time to do these. Yeah, the GLP-1 conversation I think is going to be big because we'll start small. So using those peptides in the gut, they're useful because they help us signal like responses to hunger, but also like how we shift glucose around, which has effects on lots of like a large order of other things. So what we can see is when we impact some of these peptides and GLP, not as much as some of the ancillary ones, can actually start to cause some problems as well. And we're starting to notice what those are. There is a give and take though. I will say, like my bias is I'm probably generally like in support of doing more active strategies first, but I can totally understand where it can be a big shot in the arm for people in getting some leverage on their weight, especially if when you think about the problems that can be caused just from being overweight. So I'm sensitive to that too. So I think you're just learning how do you manage this in a way where you're mitigating the downsides, taking advantage of upsides. You know, if it makes sense to do it in a more traditional way of, calorie counting and exercise for some people, that is probably worth trying. I know in a lot of places outside of the US, they make you do that with a journal first before prescribing things like this. I don't know what the utility of that is, but it's definitely we're at a point where there's it's worth the conversation. So I'll try to put that together in a meaningful way. Yeah. Dr. Genie says Weight Watchers is going to go bankrupt. I think they're actually including GLP-1s as part of their program now, which is kind of wild. I could be wrong on that. I might have made that up. Genie says, no, they're going bankrupt. Who'd have thought? Can POTS mechanisms be cumulative in my experience? So I think what you mean by that is like, can you have more than one? You kind of have it. You could think about it like a cascade where one thing can lead to the breakdown of another thing, can lead to the breakdown of another thing, and you just get in these compensatory responses. We think about it like looking at layers of an onion. That's the, kind of the trope. But where it starts as one thing and evolves, and then we see compensations laying on compensations, like almost like you duct tape something to fix it, and you got another set of duct tape over top, and you're just trying to peel away and understanding the underneath. Especially when it's like a lot of people have history of some sort of an injury, brain injury, car accident, motor vehicle accident, infection, and then that's layered, with other versions of that, and they got sick, and then something happened, and so it's not usually as simple as there's one thing that caused it. It's a lifetime of things that leads you to the moment you're in. So you have to, when we do a history, we're looking at all of it and trying to understand like how might one thing have led to the other, and how can we wind that back. So it's a big undertaking for sure. Veronica. A great nurse that kept, we're talking back to the tilt table. Had a great nurse kept pushing me to get the best numbers, I'm assuming, so no regrets. Love it. Irene asked about what is the TTT, is a tilt table test. Oh, there we go. Eileen, can I drive my camper to your place? I can't fly. Yeah, bring the camper, park it in the parking lot. We'll have a party. We'll do a cookout. We'll roast some hot dogs. But seriously, actually, we've had people use camper. Works great. It's campground nearby. We had somebody stay in a yurt. That was pretty cool. There's all sorts of options. Anybody worried about Megan Bradford? Anybody worried about tilt table test? The one they do in Dr. Magic Keiser Clinic is way different than those in the hospital settings. Good statement. Thanks for saying that, Megan. I appreciate you. And I'd like to think you're right. But also that's kind of like tooting my own horn. Matheson said, I actually love short form videos for family and friends. They need easy to digest answers to why POTS patients shouldn't push through and get more active. That's probably a pretty good insight. Breaking those down into shorter form is a little bit tougher because there's some nuance to it. And I like making shorts. I do the shorts a lot. So let me think about how to do that best. But I also want to make sure that we give it the treatment it needs. Because sometimes it just means I end up saying something polarizing, then just make people mad, but then maybe that makes them watch it anyway. So maybe we'll do that. That's a good input. Let's put that to work. Yeah, I do post a lot of shorts on YouTube. But we can run them toward these topics too. We're always looking for more things to try to do short and sweet. Cool. TikTok, Instagram, whatever your flavor is, we put them out there. Robin, you're supposed to be in bed, Robin. I love Dr. Kaiser's long form content. Hope to see more case studies from him. It's been a while. It has been a while. They take a lot of time because they don't want to get any of the numbers wrong. But I will do them. They're harder to just talk off the top of my head because I don't want to get any details wrong, but then don't want to get any of the details wrong while also leaving people in their privacy. I don't like to, I don't want to violate HIPAA number one, but also I struggle sometimes with the testimonial side, even though we have all these great people that spend time with us, just because I want it to be a history lesson for people. So it's like becomes a distant memory for them. So I don't want them thinking about it forever. But Dancing P just joining. Welcome. We're just answering questions, having a time. It's 10:15 though. I gotta go to bed soon. So I'm gonna call it soon. I'm supposed to be in bed 45 minutes ago. Because I am a bit of a debutante and I need my sleep. But Irene McBean says, so is Adopa the only way to measure changes in the cerebral blood flow or cerebral spinal fluid? It's measuring cerebral blood flow velocity. Largely, when we do it on a tilt test, we're doing it through the middle cerebral arteries. You can measure the anterior and posterior cerebral arteries as well as the vertebral arteries. But for the specific type of test that we do, it's relative to some normative data. So we use the middle cerebral arteries. And that seems to be the way. Someone brought up Illumia before, but again, as I think Carol pointed out, it does a really good job at detecting kind of like changes in the ear, and that can be indexed, but that's not really something we can use diagnostically. Yeah, maybe somebody will come up with something cool. Robin, can upper cervical kairos help with treating when seated heart rate is increased from 65 to 85 after head injury? Possibly, if that's where the best input's going to be. It's hard to know. It could be a load of things that could help, but certainly if it is a somatosensory problem where a spinal afferent's going to help, then that's your ticket. But if that may not be the ticket, I don't know. Nancy B, can POTS cause constant head pressure? Interesting question. It can, so cause and effect maybe not be the way to think about it. It can correlate to. Usually if it's constant head pressure, we want to understand why is that trigeminal system active? Is it because there is too much head pressure? Is it because it's perceiving more input that is there? Usually things that are POTS related, like we talked about just a few minutes ago before you jumped on, we talked about this pattern where people will have hypoperfusion when they stand up because the blood's rushing out of their head, but when they lay down, they'll feel a rush of pressure when they lay down. So that's not constant. It's usually going to be more episodic like that. If it's constant head pressure, then we want to think about the trigeminal system or the trigeminal nerves in the way that they're read. to understand if they're hypersensitive or if we are actually experiencing too much pressure somewhere and trying to offload that pressure. Do I use HBOT? I actually use a different tool. We use exercise with oxygen because because of the way we're trying to push oxygen through the system and use those reflexes. We have had HBOT in the past. I like using this tool better because it allows me to be a little more targeted in addressing those reflexes. But we certainly send a lot of people for HBOT, and it can be something that we recommend. But we found that the tool we use now is a tool that we like better. Peace, love, Mung Bean. I explain POTS to a friend and family, and it feels like someone has a hand around your neck when you're upright. That's probably a solid way to think about it, like you're just walking around with a little person choking you all day long. Veronica says, good analogy. Hey, Corey Black, little late to this one. I love that you're late. It means you're doing something fun. Hopefully inventing, what were we talking about? We were doing AI. We need to check in on everybody that's supposed to be building us amazing technology in the future. Corey's heading up. You're responsible for most of them. I think you're the project manager. So I'm glad you're here. Good check-in. Eileen has said that she's got constant head pressure too. Myofunctional PT said it's trigeminal also. Yeah, a lot of people experience head pressure, but a lot of them also have head injury. Something to think about. Or even they can be post-viral pretty commonly as well. So, okay, guys. I think we hit a lot of them. I think I pinned some that I might not have gotten to. I'm not sure. It's a blur. Ritvik had said early on, have you had POTS patients say that they feel their heart is not filling up with enough blood, especially if they're hydrated? I have had people say that, although not everyone for sure. Also for hyperadrenergic POTS, which we talked about. Why does puking or vomiting help with the symptoms? That's a great question. With emetic center activation, or we may be getting pressure against the heart. I want to know more about that one because that's a very specific question, and that's very interesting. Another one from Ritvik said, looking back, the beginning of POTS for me was feeling palpitations getting up to go to the bathroom. That's super common. I thought the palpitations were related to peeing, but of course it was a sudden get up. It can be, but it can also be, interestingly, for some people, if you're getting it like while you're going to the bathroom and you notice like you start out all right and then you start to feel it more as you're going, and then after, that can also be from the nociception of the bladder itself. And as you're releasing the bladder, you get these reflexive changes in the cord that can cause a change in the output, and you get the palpitations in your heart. They can also be relative to turbulence in the blood supply if you're having like an arterial or a venous compression. We don't put a lot of weight into that. I should talk more about that too. That turbulence is going to be related to something causing a restriction of pressure that kind of reverberates back to the heart for a lot of people. But it's interesting. So is it the getting up, which can be? It can also be releasing the bladder. Some people have it after they defecate as well. But it can also be just position changes or posture, or if you eat late and having a full stomach, or if you it's been a while since you've gone number 2. Sometimes that compression coming up the colon or being kind of loaded into the rectum can also cause those things as well. So it's really interesting, and that's a good aside, because I think a lot of people experience that, especially when you wake up to go to the bathroom. Shannon, do you ever see any correlation or exacerbation with people that have the MTHFR gene, which is a gene that was super popular looking at methylation capacity? Yeah, people that have difficulty with methylation have difficulty with changing the burden of toxic load. There's some interesting things to read regarding how you might consider using neuromelanin. You can use some different supplementation that helps with methylation. So those are kind of low-hanging fruit, but I always kind of think brain and activity as a first measure for sure. You see these changes, but actually over the last few years, the way that we're approaching that has changed quite a bit. Cool. Ooh, Anne, I hope you're still around. Sorry to wait to get to this one. Is a VO2 max test important? I would say for a lot of people that are dealing with these types of problems, your VO2 max is not going to be very great on a relative basis. And also, like, to do a training, the treadmill test to do a VO2 max would be real tough on a lot of people. But it's a really interesting question. Probably more for people that can sustain a higher level of activity will notice that VO2 is available. A lot of people that we see probably wouldn't even be able, you wouldn't get very far on the treadmill doing the VO2 max. And then Carol, I was misdiagnosed with POTS when I really had OH. Ooh, that makes a big difference in my comment was going to be, it makes a big difference in terms of treatment, and that's exactly what she said. Tilt table, BP 40/30 after 3 minutes is tanking. So looking at being able to look at that vascular activity, brain talking to blood vessels, wild important. But yeah, taking care of heart rate doubling, yeah, you're going to feel terrible. That was probably when we were talking about looking at people taking blood pressure medications, doing the tilt test, and being aware of the fact that the blood pressure is going to augment cerebral blood flow as well. Sorry I missed that one, Carol. That would have been very pertinent in the time frame we were talking about it. Sorry about that. All right. Back to Sandra's. Looks like we answered that one. Yeah. Okay. I think that's all the ones I had pinned. Whoa. I dumped my chat. Hold on. Let me go back to the comments now. All right. So let's just finish up with these. Corey's up late. Lots of projects. I love it. Corey's going to make probably $1 trillion figuring this stuff out. So everybody be real nice to him. Help him out. Give him some support. We love him. Megan, I feel like when you start assigning jobs to your followers, you need to go back. You're going to get a job pretty soon. We're going to get the fundraising going, and we're going to put you to work. So just be ready. Irene says, thank you. Thank you. Thanks for good questions. Ritvik, really thoughtful questions. I really appreciate you. Super sharp. Thanks for doing this. Dancing P, get some rest. Thanks so much. Such a blessing. I was happy when I found you on Instagram. Validated what you're going through. I'm glad to hear that. I know it can feel pretty lonely out there. So thanks for being here. Wait, hey, haven't seen you in a bit. Is the oxygen/exercise tool, is it available for home use? It is. I'm not going to recommend it here though, because I don't want to fling it out there and have people, I want to make sure it's the right thing for people, but maybe you could contact us privately and we could talk about that. All right. Irene says, let rest for now. So many questions, always next week. Let's keep getting better. Let's keep all of us getting a little better every day. Let's keep the way to do that. We gotta get the drum I will continue to beat is let's try to find the data points that help us know what to do. If we know what to do, we can move forward. Let's do that a little every day. Okay, team? Let's get after it. Corey says 40/30 zombied for weeks. That's the truth. I'm gonna tell one story. So I had one time where I had to get, I had anesthesia and I was at 80/40 and felt like I could not move, couldn't sit up, couldn't lift my head up, was just a train wreck. So 40/30, I cannot imagine. So you are tougher than I am. Veronica says, thanks with the heart. Appreciate you. Thanks for being here. And Robin says, thanks, Doc. I should have been sleeping. 6:30 a.m. my time now. Oh no. Robin, thanks for being here. We really appreciate it. Yeah, you guys are great. I appreciate all of you. Thanks for being here with me. 2.5 hours later, we didn't even get through the material. Whew. We got more work to do. Okay, I'll try to do my best to make it simple try to do my best to get the information out there, and we'll keep working. Okay. All right. Love you guys. Thanks for being here. Okay. I'll talk to you next week. 8 o'clock, Thursday. Invite your friends, tell your neighbors. Get one of those planes that drives around with the banners. Let's talk about it. Let's get some folks here. I appreciate you guys.